Hello, everybody. Thank you very much for this nice invitation to be here. I would like to thank Dr. Soliman, Mokhtar, and Abbas for allowing me to present some issues on patient ventilator asynchrony at the Egyptian Critical Care Summit. First of all, I would like to present my conflict of interest since I am inventor of two patents that they are related with monitoring respiratory signals in patients under mechanical ventilation, and I am founder of Better Care, which is a research and development company, a spin-off of my institution, Park Tauli University Hospital. What you see here, I mean, it's what we call MView. It's a monitor. It's a web visor that integrates waveforms for any monitor or ventilator in the ICU. So all this connectivity is agnostic. So when we want to monitor the patient ventilator asynchrony, we need to see, in that case, the respiratory signals, as you see here in these two patients, together with hemodynamics and together with, in that case, heart rate, oxygenation, and so. This is my preferred screen of monitorization. Having said that, what we don't want to see is a patient that awakes and is fighting with the ventilator. I presented this picture maybe 200 times during my presentations, but I believe it's extraordinary. It's a patient here that has diaphoresis, nasal pharynx, cyanosis, tachypnea, abdominal paradox. I mean, using all the muscles, tachycardic. This patient is not comfortable with the ventilator, has this synchrony between the patient and the ventilator. And this can cause dyspnea, discomfort, delirium, anxiety, lung injury, muscle injury, and maybe increase mortality. When we look at the types of asynchronies that the patient can present, I mean, we need to look at three periods. First of all, inspiratory period, because we can see whether, I mean, there is trigger delay and see how the inspiratory period is performing. Then we go to the transition from inspiration to expiration because things maybe happen here, such as, I mean, 2 breaths without expiration, or in that case, the patient wants to expire and cannot. And then the expiratory period, mostly because there is ineffective inspiratory effort, so a wasted effort that cannot trigger the ventilator together with auto-triggering, or maybe using the expiratory muscle contraction, a much common phenomena that we believe in the ICU. But also we can classify asynchronies in two ways. The ones that there is insufficient assistance of the ventilator, and the landmark asynchrony is high respiratory drive, and the ones when there is over-assistance. And when there is over-assistance, the drive is quite low, and maybe ineffective efforts can appear. If we just a brief summary in that case of the asynchronies, when we look at when the inspiratory time of the patient, such as here, is longer in that case than the inspiratory time of the ventilator. Then at the end of the ventilator inspiratory time, the patient is still inspiring. And then if we look at the flow and the pressure waveforms on the ventilator, we will see, I mean, this type of asynchrony that essentially occurs during, in that case, the inspiration. This is, whoops, sorry. This is a tracing of this asynchrony, which is called premature or short cycling, a very common asynchrony, because the patients breathe not at the same inspiratory time always. So this patient is breathing here in pressure support, it's triggering the ventilator, but here, I mean, uses a longer inspiratory time compared with this one. So at the end of the, in that case, machine inspiratory time, the patient is still inspiring, and then there is this deformation in the expiratory flow. At the bedside, we do not have esophageal this manometry, therefore we need to know this specific pattern to recognize when we need, in that case, to adjust or not the ventilator. This is another asynchrony. When this inspiratory time of the patient, the prolonged inspiratory time, I mean continuous after the ventilator has ended the ventilator inspiratory time, it may trigger another breath with almost or no expiration in the middle. This can occur in pressure control. This can occur in volume control, and usually there is a double or almost double tidal volume going in, which is able to cause, injury if this phenomenon happen repeatedly and repeatedly. This is nicely demonstrated here. This is a paper from our group showing that those breaths that there is breath stacking, those breaths with double cycling, double triggering, that producing breath stacking, the tidal volume was almost double in all these modes: pressure control, volume control, or volume control decelerated flow. And clearly this can cause a strain, which is an excess of lung deformation, or a stress, which is an excessive pressure, in that case, to the lungs. Here we have a clinical example of breath stacking, showing clusters of double cycling or breath stacking, which is a period where the patient, is fighting with the ventilator, has asynchronies. You will see here some short cycling, as I show, but in some of them, breath stacking due to double cycling, short cycling, and this all the time. And this happens mainly during that period of time, which is during these 26 minutes, for whatever reason, because the patient was more awake, had delirium, has pain, or whatever. This, now I will show later on that this is clearly deleterious for the patient. Again, just a word on ineffective effort. Usually this happens when there is over-assistance. This is tracing of pressure, the tracing of pressure support ventilation. This is flow, this is airway pressure, this is esophageal pressure. This patient has too much pressure support. As a consequence, this patient is, has over-assisted, has some hyperinflation. That's why there is a wasted effort here. It cannot trigger the ventilator because this negative esophageal, this negative intrathoracic pressure cannot trigger the ventilator. Usually, this is caused by too much pressure support, when there is auto-PEEP, inadequate triggering, or inadequate cycling off, in that case, in pressure support. This can happen together with other asynchronies. Again, this is a tracing of volume control. This is flow, this is pressure, this is volume, and this patient presents here an ineffective effort. Here, a double cycling with breath stacking, almost doubling tidal volume. Again, there is a breath stacking here, ineffective effort, breath stacking, ineffective effort. So, clearly at the bedside, this can be identified. And when we identify this, we can, the interpretation, it's, there is an increase in that case in the inspiratory time that overinflates the lung. That's why there is an ineffective here. Again, overinflation, wasted effort, and so on. So the physiology at the bedside happens with the observation of the patient and observation of the ventilator screen to identify this type of desynchronies. Talking with desynchronies, we must talk with a new asynchrony, which is called reverse triggering. Reverse triggering occurs when a time cycled, and in that case, a time cycled breath from the ventilator causes, as you will see here, a contraction of the inspiratory muscles through several spinal reflexes. This is a new asynchrony that now it is discovered that happens very often during mechanical ventilation. If the patient contracts the inspiratory muscles in the middle of the ventilator insufflation, it can have a type of injury to the diaphragm that is called eccentric, because now it is in a not adequate working place of the muscle. Again, when this is a reverse triggering causing breath stacking, as you can see here, and this is a reverse triggering occurring here a little bit earlier during inspiration, which is not causing breath stacking. If we take a look, forget about the esophageal tracing, only in the pressure and in the flow tracing, we need to be able to see that there is no effort of the patient at the beginning of inspiration. This is pressure control. This is time cycle. and then in the middle of inspiration, this variation in flow caused because the patient wants more air, as you will see here, and increases the flow due to active inspiration. In this paper, we want, in that case, to compare breath without reverse triggering without breath stacking, reverse triggering with breath stacking, and synchronous pressure support breath. And you will see that in breath that reverse triggering do not cause breath stacking, the amplitude of the muscular pressure, the negative thoracic pressure measured with the esophageal balloons, is comparable, in that case, more or less with the pressure support. And the most increase in this esophageal pressure causing probably, stress and strain occurs in that case when the reverse triggering causes in breath stacking. Saying that again, at the bedside, we need to pay attention because reverse triggering maybe it can occur when the patient starts to breathe and is a reaction when the patient is off sedation and starts to interact with the mechanical ventilator. However, breath stacking is not physiologic and breath stacking can cause stress and strain. This is just an experimental animal to demonstrate that what was I commenting. This is experimental RADS by the group of Yoshida and Laurent Brochard. And you have here the tracings of airway pressure, flow, esophageal pressure. Clearly, this is a reverse triggering breath. And here, this is local lung stretch demonstrated by impedance tomography. And it can be seen that in the dependent lung areas, there is a stretch, there is deformation caused by reverse triggering. So reverse triggering, again, can cause deformation of the lung, increasing the pressure up to a point that can cause lung injury. So another asynchrony. And this is the asynchrony when there is clearly is the opposite of what we were commenting. When the ventilator inspiratory time is longer than the patient inspiratory time. In other words, if the patient stops here and wants to expire, the ventilator do not allow the patient to expire and the patient is blowing. It's blowing, it's contracting the expiratory muscles because he wants to enter into the expiration, but the ventilator do not allow the patient to do so. And here is an old paper of Martin Tobin, a very nice paper where, it's showing again in pressure support that the patient is flow, breathing here, airway pressure, and in the middle of the machine inspiration, the cycling off has not occurred yet. The patient wants to expire, and his is the electrical activity of the transversus abdominis. So there is a contraction, an electrical activation of the, expiratory muscles that they want, in that case, to expire. The patient wants to expire, but cannot because the expiratory valve is still closed because the patient is still in the inspiratory. So this can cause really discomfort. So we need to look at specifically at these profiles, first to the patient and then to this spike in pressure support to recognize this asynchrony. So asynchronies in general are always present. When we look at in a series of patients and we compute all breaths, such as in this investigation here, we find that asynchronies, all patients present asynchronies, which is the most common asynchrony about triggering, ineffective efforts, and phase asynchrony, short cycling and prolonged cycling. From intubation, in that case, to extubation. And this is unpredictable. Asynchronies can happen, at the more or less during the first days, but a lot here in the day 7 or 8, in a very low levels in this patient at the beginning of the mechanical ventilation or always. Therefore, we need to pay attention, not we, nurses, respiratory therapists, physicians, everybody at the bedside needs to pay attention to the asynchronies. This paper was not designed, to take results or to have results about outcome, but what we found is that when the asynchrony index is higher than 10%, ICU mortality was higher and hospital mortality, but look at the numbers. It happened only in 4 patients. But maybe this tells us that when asynchronies are exaggerated, or when asynchronies occur that cause stress and serious stress and strain, maybe had outcome implications. Again, in the paper of Rochard, when asynchrony index was higher than 10%, days on mechanical ventilation were, there were more days on mechanical ventilation, more percentage of tracheostomies, and more days more days on prolonged mechanical ventilation, but mortality was the same. So again, this suggests that when the asynchronies are higher, maybe, there are some outcome outputs that need to be controlled. We perform an analysis here in 139 patients, and we compare the effect of asynchronies on outcome, and also we, record SOFA. We use this kind of Bayesian John model, a kind of advanced statistical analysis. And interestingly, we see that not only asynchronies were associated with mortality, it seems that they were associated, in that case, with survival. So this seems a contradiction, but it's not. Clearly, SOFA was associated, in that case, with a poor outcome. Let me see an example with you here. This is a patient who died. Patient day 1, day 2, day 3, day 4. Here is, in the triangles, it's asynchrony. Well, here, let me see. The triangle is the asynchronies, and this is, in that case, SOFA, as you will see, and this is alive, and this patient is dead. You see that in the day 2, in the day 3, the SOFA increases, the day 4, the SOFA increases, and the asynchronies remain low, and this patient died. A patient that they were alive, the patient that they were alive, the SOFA decreases day 1 and day 2, the asynchrony, it seems to stay the same, but at day 3, asynchrony increases, SOFA decreases, asynchrony increases, SOFA decreases. The probability to stay alive is high, the probability to die is, very, very low. Why that? Because probably when the patients start to interact with the mechanical ventilation, because the sedation is off and the patient is doing okay, up to a certain point, there are some asynchronies or desynchronies between the patient and the ventilator. The key point is when those asynchronies turn bad. So maybe we can coin the term permissive asynchronies. The group of Georgopoulos and Vaporidi analyzed clusters of asynchronies of ineffective effort. In other words, this is ineffective efforts of a patient, and in this period here, there is an increase in power, so the number of ineffective efforts increase, and the duration of this period also was longer. And interestingly, what they found that the asynchrony index was not related with outcome, and it was related, in that case, the power and the duration of these clusters. They utilized, for them, a cluster was a 3 minutes period with more than 30 ineffective efforts. In the Brazilian group, in a series of more than 100 patients, we measure the same, using the same definition of clusters, 3 minute period, but in that case of clusters of double triggering. And this is, we define low duration of clusters, less than 12 hours in the total time of mechanical ventilation with clusters, and high duration, more than 12 hours, and fulfilling this definition the same as Georgopoulos group. Here is two patients, one with low, one with high, and the survival probability was higher in patients with less than 12 hours with clusters. And this is very interesting. Then, in another cohort of patients, this is in patients in Spain, not in Brazil, we analyze 180 patients when similarly we define same definition of clusters, and we look at clusters of double cycling and ineffective effort. And this is a cluster, you see. This is ineffective effort, this is double cycling, and so on. And this constitutes a cluster, and this is a little portion of that cluster. Looking at that, we found that all patients had clusters, all of them. Clusters were a little bit less in the first 2 days, probably because the patients were more sedated or maybe with neuromuscular blockade agents. Between the first 2 days and the rest of the period under mechanical ventilation, there were no difference on the power, on the durations, but mathematical models said that clusters were associated with survival, but the clusters with higher power, let's say lots of asynchronies inside the period and had more duration, so that lasted for more time, were negatively associated with survival, either in total and in the first period of mechanical ventilation. Again, this tells us that asynchronies per se are not wrong. What is wrong is how these asynchronies appear and perform. That's why we need, some tools for monitoring. Close to finishing, when we look at this, also, if we have, if you use in that case Haydn-Markov models, which is a complex algorithms, we can predict how a patient will be in the next 15 minutes. In other words, in my unit, if one patient had a poor patient ventilator interaction, in the next 15 minutes, probably the 80% will remain with this poor patient ventilator interaction. That means that in the ICUs, we need sometimes observation because some asynchronies can be really undetected if we are not looking at the screen of the ventilator. And more interestingly, when we have analyzed complex patient ventilator interactions using entropy, which is a kind of chaos detector, we can identify this complex patient ventilator interaction that in some patients lead to self-extubation. So this is an ongoing work because maybe we can predict in advance in a certain percentage of a patient, and we can prevent from unplanned extubations that clearly are associated with higher mortality. To finish, high drive. The patients can be passively ventilated, so the patient is not doing nothing, respiratory muscles are completely passive, or the patients can breathe, in that case, exhibiting a high inspiratory effort, so the patient is doing part or total of the work of breathing. When that happens, we talk about inspiratory flow mismatch, flow starvation, that can, for example, in this example, the patient is doing the total work of breathing. It's inspiring. It's a huge patient effort during the whole inspiration, and this can cause dyspnea and can cause air hunger, and this happens at each breath. When that happens at each breath, nowadays, only looking at the screen of the patient and examining the patient, we can detect this important asynchrony. Flow dysynchrony occurs when the ventilator fails for whatever reason, patient or machine related, to meet the patient's flow demand. This can cause dyspnea and air hunger. Then we can go inside the causes of increased respiratory drive. Pain, anxiety, discomfort, inflammation, maybe the virus, the new virus. When there is acidosis at the space and shunt or hypoxemia, on when there is, in that case, severe lung inflammation that projects, in that case, to the respiratory center. When that happens, the consequences of this high respiratory drive is an increase in the transpulmonary and in the transvascular pressure, because there is a decrease in alveolar volume, increase in tidal volume, pendulum, increase in esophageal swings, increase in respiratory rate that can cause lung injury. in all these forms that we really know in the ICU. And this can cause self-inflicting lung injury, and if this perpetuates breath by breath, can affect clearly outcome. When we look at a dyspnea in patients with COVID, we have discovered or coined the term of silent hypoxemia, but this is not new, okay? When, there is silent hypoxemia in the context of not an increase in minute ventilation, and in the context, in that case, of normal respiratory mechanics, and this is caused by a mismatch with ventilation and perfusion, only a mismatch, there is no dyspnea. However, when the lungs get worse because there is more inflammation, compliance decreases, edema increases, this causes more work effort, increases respiratory rate, increases effort, this inspiratory drive, and that's why in the pandemic, many clinicians use neuromuscular blocking agents. So the dyspnea increases when there is, in that case, an impairment in the lung function that increases then minute ventilation, increases effort, and then causes dyspnea. Dyspnea has been detected in patients with COVID and has been postulated that it contributes to the evolution for this pattern, which is called low distress and goes to recovery, but in those that the lung impairs, this increased inspiratory effort can further aggravate lung inflammation and have an evolution from high distress to the fibrotic type. In many patients, this is a reality in patients with RADS. In fact, in COVID-19 RADS, it has been found that the patients who present with higher P.1, and then the patients that have that at occlusion pressure, so the negative inspiratory effort in that case is lower than -10, are the patients that cannot get off the ventilator and can have, a relapse on the mechanical ventilation. So in COVID-19, the P of 1 was frequently above 3.5, suggesting high neural respiratory drive. Here are some examples. This is a COVID-19 RADS with high respiratory drive. At the bedside, this patient is in assist control with accelerated flow, which is not my favorite, but it's there. And the peak inspiratory flow is 58, but this patient has a high drive. The ventilator pressurizes, but immediately there is this, huge decrease in pressure because there is a patient high respiratory drive. This is another example. In that case, caused, as you will see here, and I'll let you think for a while, by reverse triggering. There is no inspiratory effort by the patient here. This is a time cycled machine that immediately triggers an inspiratory effort of the patient, but not in this breath. It occurs only in these 3 breaths, but in that breath, the patient's triggers the ventilator. That's why there is not, the pressurization is not similar as here, because the patient is increasing the work of breathing in that case from the beginning. It's triggering the respiration and increases the work of breathing. Here is done just after 100 or maybe a little bit more milliseconds of the time cycled breath initiation. Having said that, another example here where all the breaths are reverse triggering, but here the swing of the airway pressure is higher. So the negative esophageal swing is very higher. So this causes a stress and a strain. And in this example, this happens every breath. That's why we need to pay attention, because if this happens to every breath and lasts for minutes or hours, in some patients, this can cause a strong effort, large transpulmonary pressures, pendulum deformation, large stress, and maybe patient self-inflicted lung injury that we need, in that case, to treat and act immediately. To conclude, ventilatory synchrony issues today, it's Asynchronies are present during all periods of mechanical ventilation and in all modes. Asynchronies in general are probably not related with a bad outcome. However, high cumulative duration of clusters of asynchronies, double triggering, and wasted efforts are associated with poor prognosis, shorter survival, less ventilatory free days, longer mechanical ventilation, and longer ICU stay. Sedation is not a solution for these problems, neither to control the respiratory drive nor to control asynchronies. Connectivity, interoperability, and artificial intelligence is needed to better understand patient-ventilator interaction throughout the ICU stay. But the most important of all of this, do not forget that ventilator management demands greater understanding of physiological principles. That's why patient examination and a stay there and try to understand completely what's the physiology behind a patient under mechanical ventilation is a must in critical care. Thank you very much.